much, but I think I believe in the suburbs, they're kind of coming more to the clinics.
Coming more?
Yeah, in the suburbs. But in the main city, they're more scared.
Really? Well, but we are now, we started slow, but after 1 month of complete lockdown, then we started just with surgery, and then we'll also with clinics.
The cities, people are not moving too much, but I think I believe in the suburbs, they're kind of coming more to the clinics.
Coming more?
Yeah, in the suburbs. But in the main city, they're more scared. There's an echo coming from somewhere.
Yeah, it's all right. Yeah, Professor Boris is with us, I think.
Yeah, Dr. Boris, welcome.
Hello, Boris.
Hello. Looks like he's
Hi,
at work.
Boris.
Yeah, hi guys.
Looking smart.
So I think everybody is here, and it's 7:30, so we can start.
Yes.
Right. Yep.
Bangladesh Eye Hospital and Institute is going to organize a series of webinars on ophthalmology. Ophthalmology Webinar 2020, this 19th and 26th of June, and 4th, 10th, and 17th of July 2020 at 7:30 p.m. Bangladesh Standard Time. Big names, great surgeons, passionate teachers, creative innovators, supportive peers of ophthalmology will be speaking on current trends, topics, managing difficult situations about their innovations. Join the webinar where you will have the chance to hear their thoughts, clarify your queries, and know what goes in their heads and minds.
Thank you all for joining from all over the world. And I welcome on behalf of Bangladesh Eye Hospital and Institute, everybody. And we have a great team of speakers and panelists today. And they are not just speakers, but innovators themselves who has got patent of many devices among their name. So before I start, I just want to introduce all the speakers, but I think they are just world famous and none of them needs any introduction. Dr. Boris Melyugin, he is the professor of ophthalmology, PhD holder, and he is the Director General of R&D and Education at Fyodorov Eye Microsurgery and Institution. He is the president of the Russian Ophthalmic Society. He has got many awards internationally and has performed live surgeries in many national and international meetings. As we know, he is a renowned educator of ophthalmology, strongly associated with the American Academy of Ophthalmology, ICO, and International Intraocular Implant Club member since 2009. Dr. Ehud Asia is the professor of ophthalmology in Sackler Faculty of Medicine, Tel Aviv University, Israel. He is the medical director and senior partner of Ein Tel Eye Center, Tel Aviv. and he is the director of Center of Applied Eye Research, Department of Ophthalmology, Meir Medical Center. He has got more than 160 peer-reviewed papers, over 50 other publications, and 31 chapters in different books. And he owns several patent and development for the different instrument and techniques, and he has received several achievements awards like Limb Medal, and he has delivered the Bringhurst Medal lecture. Dr. Shubhen Bhattacharjee, he is a eye surgeon, innovator, entrepreneur. He is the director at Noyon Eye Center and Med Event Devices. He's got global patent for BHEX Pupil Expander. Of course, he's going to talk on that today. And he has got some innovator and gold medalist at national and international level. He has been awarded also nationally and internationally. Dr. Thanapong, he is the chief of uveitis unit and retina unit at Chulalongkorn University, Thailand. And he is the scientific program committee of Thai Society of Cataract and Refractive Surgeons, and also he is among the scientific program committee of Thai Retina Society. And he is associated with Information and Technology Committee of Thai Ocular Immunology and Inflammation Society. And I will be the moderator for today's session. Just before we start, we have a condolence that we just lost one of our colleagues. He was an excellent cataract surgeon and a director of Bangladesh Eye Hospital and Institute. Just lost him because of a sudden cardiac arrest 2 days back. Just to get back on the things, that this program will be live streamed on YouTube and Facebook of Bangladesh Eye Hospital Academic. So there will be scope to join from there. And while we will have the presentation, there is a Q&A box. Please pour in all your questions to all these great innovators and surgeons and speakers. So now I would request Professor Ehud Asia to share his screen and make the presentation, please. Professor Asia.
Oh yeah, thank you. I'm trying to share my screen now. Okay, there we are. Okay, well, thank you very much. First of all, I would like to thank Dr. Anwar and the meeting organizers for this opportunity to participate in this exciting webinar. And I will be talking about our clinical experience with the APX. This is a very exciting topic for me. First of all, I would like to acknowledge that I do have proprietary interest in what I'm going to show now today. Small pupil is indeed a big problem, and there are many ways to dilate the small pupil. It can be done either by stretching or by sphincterotomies. This has been abandoned almost, by hooks, which are very popular, or by a variety of rings. Most popular are the hooks. They have the advantages that they are very small and quite inexpensive. One needs about 3 to 5 side port incision to insert them, and they do require some time to put in and some time to take out. They are not very easy to manipulate, but they are very favorable, and they can also assist in capsular support in cases of phakic pseudodonasis. Rings come in 2 forms. They can be either open rings or closed rings. There are a variety of them. The open rings are shown here. Really, kind of Brava came up with a new one. And the closed ring are even more popular. The most popular of which is the Malugin ring, which is about 80% of the American market, for example. And there are other rings in the market, including we have here today, 2 of the inventors, Malugin and Bhattacharjee, which is BHEX technique. But what I'm going to show you now today is a different concept. It's a different type of a pupil expander. And one more word about these closed rings. The main advantage is they can be inserted through the main incision. However, they do require intraocular manipulation to manipulate, to put in, to take out this type of rings. I'm going to present to you today this different concept of a pupil expander, and this is the APX that we developed. The concept is quite intuitive. This is what one would do if he wants to open up a small rubber band. Then with 2 hands and 4 fingers, probably this is what anybody would do intuitively. So we take the same principle of this 2x motion and we apply it clinically to the eye. This is what the APX looks like. It's made of plastic. It has a nitinol spring. The tips are blunt, so it would not hurt the edges of the sphincter, and it is disposable. It comes in a set with 2 designated forceps and 2 pieces of the APXs. And let me start by showing you how it is done regularly in a normal routine small pupil. So we start with doing 2 paracentesis, 2 side port incision with 19 gauge step knife. And then we insert it from each of the sides from 2 opposite sides. This is the case of a patient with diabetes, small pupil. This is a 19 gauge incision. Now we insert the APX all the way and open it up slowly. Just make sure that the tips are located behind the iris through the pupil and open it up. This is it. Note that we do not need to do any intraocular manipulation with any other instruments. Everything is done from the outside by using these designated forceps. The other thing is the 2 incisions are not one opposite to the other, skewed it a little bit up, so it will create kind of a trapezoidal shape opening. And that provides here a device-free area for all our instruments. From here on, we do a regular routine phacosurgery, so the opening which is done either from the side temporal approach or superiorly, and we use routine regular technique by direct visualization. Following removal of all the lens material, we can implant the intraocular lens. Again, it is all done under direct visualization, and note that it does not interfere with the surgical maneuvers. Even if we need to override with the hook over this piece of the device, it does not interfere. Removal of the APXs is done with the same designated forceps. We just close and pull it out. That's simple. Close and pull it out. No need for any other manipulations, and the pupil resumes its original shape. So now let's go and see some other cases, some unique cases. And first I would like to show an alternative technique for surgeons who may fear that they may touch the capsule with the device. What we advise to do is to open it up, fill some more viscoelastic in between the iris and the pupil, and then come from the outside in, from the iris towards the center of the pupil. So this way, the chance of hitting the capsule is minimal. We open up and then close it a little bit and make sure that we're in the right position, and then release the tension, and then to take it out, just close and pull it out. This is a case of a patient with a hypermature cataract. We can see through the small pupil, we can see the fibrotic tissue of this patient who was irradiated for melanoma. The bleeding comes from the manual stretching, and now we insert the APX, allow it to open up so we can see the entire anterior capsule before we cut it, and do the same on the other side. Now, because this is a fibrotic tissue, we cannot just take it out with a capsulorhexis. So we need a good visualization of the central area. And now we cut the fibrotic anterior capsule with scissors from one side and from the other side, and take it out with forceps. In this case, you need to have a good visualization. Now we see the brown cataract, and implantation of the intraocular lens is again under direct visualization, and following implantation, we pull out the APXs with this designated forceps. Here is a patient with hypermature cataract. It's actually a Morganian cataract. She was blind for 15 years. We did not know what to expect. So now we stain the capsule with vision blue, make a small hole and aspirate it to find out this Morganian small and very dense cataract. We can see the calcification over the anterior capsule, remove the lens, put in another lens, and then take it out, and the pupil comes down to its original shape. Suturing of an intraocular lens also required good visualization. We need to see where the needle goes in and out. It needs to come underneath the optic and then in front of the optics, take it out. And this last case is a patient with severe phacodonesis because of pseudoexfoliation. We dilate the pupil, perform the cataract removal, and we were lucky to have to maintain an intact capsule. However, it may not be sufficient to support the lens, so we need the capsule stabilizing device. And I'm using here the anchor, which we designed several years ago. Now the anchor is in place, the lens is stable, and we can take out the APX from one side and from the other side, and this is at the end of the operation. So just to summarize our experience, we did use the APXs using, in the cases of pseudoexfoliation, of IFIS, of course, uveitis with severe synechia, anterior and posterior, all kind of cataract, including hypermature cataract, narrow angles, including nanophthalmos, colobomas, scleral fixation, iris fixation, parosplantar vitrectomy, and all kind of subluxation of lenses, including Marfan with capsule stabilizing devices. And we find that this APX effectively dilates small pupils, both in routine and in complex cases. Once again, I would like to thank the meeting organizing for the chance to participate in this symposium, and thank you very much.
Thank you, Dr. Ehud Assia. That was an excellent presentation and something new in our part. As this is not available, I'm sure there will be many persons who will be willing to use that. And we'll have a lot of questions after all the presentations are over. So now I invite Professor Boris Malyugin to share his screen and make the presentation.
Okay. Can you hear me?
We can hear you.
Okay, thank you. First of all, I want to thank Dr. Anwar for the kind invitation. I never been to your nice country, which is rich with nature and talented people, but I hope I will be able to join you someday, not on the virtual space, but also in person. I will be talking today about IFIS update, and I will be also talking about some devices that I have proprietary interest in. So intraoperative floppy iris syndrome is actually well known since 2005, and having a classical triad of symptoms, the iris that is floppy and billowing, there is a propensity for the iris to prolapse into the phaco and side port incision, and there is a progressive pupillary constriction during the surgery as shown in that case, which was, and we know that this symptom, the syndrome was discovered by David Chang and John Campbell. And they actually analyzed the history of the medical records, and they discovered that 10 out of 16 patients in taking tamsulosin had this problem. But now we know that this is not only alpha 1A inhibitors that causes this symptom, but there are also other antipsychotic drugs and the drugs that lowers the systemic blood pressure. What is the pathomechanism? As shown here, this is a postmortem eye. On the upper right picture, you see that the iris dilated muscle is much thicker than on the lower right picture, patient having tamsulosin, and that is the reason for this syndrome to appear. And it also can be seen with the help of anterior segment OCT, and you can see here, this is the dilation to sphincter ratio as shown here, and we see that the patient having tamsulosin as opposed to control, this ratio is very much different and that is the reason for that syndrome to appear. So there are also localization of these receptors that are binding with these drugs, also in some other tissues such as vessels, arteriolars. So that might be also one of the reasons for this syndrome to happen. There are certain risk factors, gender, which is obvious, age, hypertension, and also short axil length that are associated with this syndrome. The pupil that is smaller than 7 millimeter is a very sensitive criteria that help us to predict whether or not this person will have intraoperative floppy iris syndrome, as it's shown here. In patients having smaller pupils, there is a fourfold risk of this syndrome to happen than in patients that are having a regular size of the pupil. So there are other different risk factors. We know that the pupil is sometimes hard to judge because of the size of the cornea. So there is a ratio in between the corneal diameter and the pupil diameter, which is considered to be more uniform factor that help us to predict whether or not this will happen. How about incidence? Incidence is very variable. However, from the latest publications on a massive amount of people, we can see that in the regular populations, the incidence is about 10%. However, in patients intaking tamsulosin, the chance of this ranges in between 40 and 86, and it's lower in Asian population compared to the Western or European population. How we classify the syndrome: mild, moderate, and severe, depending on the number of symptoms to appear. 1, 2, or in severe case, all 3 are happening in that patient. So the IFIS can happen even early, right after the start of the intake of tamsulosin, which was reported in that publication to be 48 hours after the start of the medication. It is associated with complications such as ocular inflammation, posterior capsule rupture, capsule tears, visual loss, iris trauma, and cystoid macular edema. Capsule rupture, which is one of the most significant complications in cataract surgery, varies in between 7 and 12%. So we need to be aware of that and to take every precaution to avoid that problem. Loss of iris tissue was also being reported, and shown here, sometimes it's not only cosmetic, but also a functional effect of loss of this tissue. Pre-op medications, it was shown that adding atropine and non-steroidal anti-inflammatory drugs can actually help you to prevent intraoperative floppy iris syndrome based on the findings by Dr. Visco. Intracameral injection of mydriatic agent, that's shown here, helps you to expand the pupil very significantly, and also to prevent the syndrome by strengthening the periphery of the iris and increasing biomechanical stability of the iris. How about the surgical technique? It is recommended to use elongated corneal incisions, to use gentle hydrodissection, because excessive hydrodissection may aggravate the prolapse of the iris, lower fluidic parameters, and keeping the irrigation flow above the iris plane, which is the recommendation more relevant for bimanual phacoemulsification rather than for coaxial that most of us use. Surgery duration in intraoperative floppy iris syndrome is much longer, even in experienced hand of prepared surgeon. There are some evidences showing that combining viscoelastics, but like in here, by adding dispersive viscoelastic, placing it near the cornea, and adding the viscoadaptive, at the very center and leaving a little bit of space filled with BSS may help you to stabilize the iris and to avoid problems. Diamond iris configuration, iris retractors configuration as proposed by Dr. Thomas Oetting and Dr. Dubs, as shown here. The major invention here is that when you place the one of the hooks below the main incision, that helps you to stabilize the iris, to prevent prolapse, and also to prevent trauma from the hand pieces that you insert in and out of the eye, which is also very useful. And also some rings that one of them I designed show to be quite helpful in these cases. This is the Malubin ring, which comes with the holders and different sizes, and it was shown in 2008 publication by David Chang that the use of that device helps you to prevent intraoperative floppy iris syndrome in severe and moderate cases. So how is it being used? This is the case, starts from the pupil that is quite big. However, as soon as we progressed during the surgery and viscoelastic left the anterior chamber, we see that the iris become floppy. It started to prolapse through the main and side port incision. And obviously, the surgeon will be having difficulties in continuing successfully finishing that surgery. So that's why the decision here was to stop at some point to avoid additional trauma to the iris, inject viscoelastic, and we see that after injection of viscoelastic, the pupil again expanded a little bit. However, that is temporary, because as soon as viscoelastic will go out, it will start constricting again. So the ring is injected, and the case continued successfully, followed by irrigation aspiration of the cortical material and insertion of the CTR of the IOL into the capsular bag. And as shown here, the case completed successfully, although there is a little bit of depigmentation here. However, the case was, there was no any major events in that case. So why is it a good device to support the iris? Because we do have 8 iris fixation points. In spite of the square configuration of that ring, 8 fixation points make the pupil round and stabilize the iris very, very effectively. So it was shown in many publications, the pupil expansion rings are much easier to use, require less operative time. They do not require extra incisions, provide stable pupil, and minimize pupil deformity postoperatively. And also there are several different modifications of the rings are currently on the market, so the surgeon may choose whatever device he's more comfortable with. And it was shown that as opposed to the iris hooks, as shown on that graph, consultants, which is in blue, and trainees, which is in orange, I see that the time needed for the surgery was much bigger for experienced and inexperienced surgeon than for the surgeons utilizing the pupil expansion device, which I believe a very important finding of that study. So iris hooks cases took on average 10 minutes longer for experienced surgeon and 18 minutes longer for the trainees. So my take-home messages for you, first of all, we need to check patient history, because what medication he uses may have us give us the idea whether or not this patient may have pupil issues during cataract surgery. If the pupil does not constrict well at examination, expands well at examination, preoperative atropine and non-steroidals may help. Intracameral mydriatics should be considered to achieve intraoperative mydriasis, and lowering vacuum and aspiration settings is obviously helpful. use OVD combination as described earlier, iris hooks, and of course my preference is the pupil expansion device, which I invented, and I thank you very much for your kind attention.
Thank you, Professor Boris. That was an excellent presentation, and we have been hearing you over the years in different conferences, and we would love to have you here. You know, once this is gone, we are sure we're going to have you here.
We'll be happy to come.
Yes. I would request Dr. Shuven.
Yes.
To present.
Yes. If
talk.
Dr. Boris can stop sharing his screen, please. Yeah. Yeah. Thank you, Dr. Ishtiaq, Dr. Professor Nazrul Islam, and Dr. Khair Chaudhary for this kind invitation. For many of you, my friends in Bangladesh, you may not know that actually I was born in India, but my parents are from East Bengal or Bangladesh. Baba is from Pabna and Ma is from Kumilla. So I'm very much, we are very much the same. Though I haven't had the opportunity, so I'll be visiting. Now, I have a very unstable internet. So Ishtiaq Bhai has been very kind. He will be playing a video with a voiceover. I've made my slide presentation into a video. So Ishtiaq Bhai will be playing it over there for you. And just if Ishtiaq, if you can allow me to share my screen, I'll just show one slide.
I think if I start
yeah,
sharing...
I'll share. Just a minute. I'll share my mine first. If you can allow me to just share one slide, please.
Yeah. Okay. Go on, please.
Yeah. Yeah. There's a recent article I wrote for. Can you see my screen?
Yeah, we can see it.
Oh, I can't see. Yeah. You can see my screen, I suppose. Yeah. This is an article. Can you see that 10 tips for phaco emulsification in small pool? This I wrote for e-author. This is
yes.
What happened to my screen?
You can see it.
My screen is gone. Okay. So that is something which is quite a valuable, and I'd encourage everybody to read this. Now I will request Dr. Ishtiaq Anwar to kindly play my video, which has basically, it's a slide presentation converted into a video.
Yeah. So hopefully this works here.
I'm Suvin Bhattacharjee, and I am honored to speak about the BHEX Pupil Expander. The awards testify that the BHEX has indeed redefined pupil expansion. I thank Dr. Deepak, Dr. Nito, Dr. Sri, Dr. Ajay, and Dr. Dev Dulal for the videos. BHEX is a globally patented, simple, safe, and affordable pupil expander, made in India and shipped worldwide by MedInvent devices. We are currently exporting to quite a few countries. The 75 micron profile is 1/10 the thickness of other devices. Hexagon with notches and flanges. The housing presents the preloaded device at the incision, and the BHEX 23 gauge forceps advances it through the incision. As alternate flanges are tucked under the iris, the pupil expands. The iris bends at the notches, while the BHEX remains in a single plane. Notches are disengaged and the device is removed through the main incision. In fact, the BHEX can exit through a 1 mm side port incision, which no other device can. The need for a better pupil expander stemmed from the fact that the scrolls of the Malugan ring, though brilliant, are biplanar and are responsible for snagging the incision and crushing of the iris. The radically different, inventive step is the uniplanar design of the BHEX. The scrolls of the Mulligan ring are biplanar and they snag the incision, require an injector and a bulky tube. On the other hand, the notches and flanges of the BHEX are thin and in a single plane, which obviates the need of an injector, and the device glides in and out of very small incisions. In the Mulligan ring, the scrolls straddle the pupil margin, while in the BHEX, the pupil margin straddles the notches. The iris bends harmlessly and reversibly at the notches, while the BHEX remains in a single plane. Publications have endorsed its usefulness in difficult cataract and vitreoretinal surgery. Chang and Campbell published that unlike non-elastic pupils, the IFIS pupil immediately snaps back when stressed. So we have an elastic pupil which is like a rubber band and any device will work. whereas the non-elastic pupil is like a string and it can be only torn or broken and it requires a strong and bulky expander. The choice depends on how you wish to tear the rigid pupil. With two Kuglen hooks, the hair-thin BX allows a lot of space in the AC for instruments. To tear with the pupil expander, it has to be bulky and that would obstruct instruments. This is an elastic pupil. As alternate flanges are tucked, the pupil expands to 5.5 millimeter for easy phacoemulsification and IOL implantation. The flanges are untucked and the B-hex literally walks out of the main incision. And here, the B-hex is removed easily through a 1 millimeter side port incision, which no other pupil expander can do and is very useful in tight situations. A rigid pupil and a hard cataract. A bimanual stretch makes it easier to tuck the flanges of the B-hex. As we can see, the 5.5 millimeter pupil is more than adequate to emulsify even this hard a cataract. And once again, removal is so easy. This is a rigid pupil with a fibrotic membrane. Stretching was not attempted and only the fibrotic membrane was removed. When the pupil still remains rigid, bimanual tucking of the flanges using the forceps and the iris hook or Kuglen hook helps engage the B-hex with ease. And we have such good visibility for surgery. Despite being rigid and fibrotic, we have a nice round pupil. This is an extremely shallow antechamber, and we can see how the 75 micron thin B-hex can easily be tucked under the pupil margin. Despite the shallow chamber, every step is so controlled and safe, and it allows so much space for the phaco probe and other instruments. The B-hex never comes in the way of IOL implantation. Here, the pupil becomes small as phaco is commenced. A little viscoelastic lifts up the iris from the capsulorhexis. The uniplanar design and open notches ensure that the capsulorhexis is not engaged as the flanges are tucked. As the flanges are tucked and advanced, there is instant confirmation. And now we are back to our comfort zone. IFIS and pupil expansion devices. If we leave iris billowing, there is meiosis and iris prolapse. For meiosis, iris hooks and pupil expanders both will work because they provide constant pupil size, which provides good visibility for safe phacoemulsification. Whereas in iris prolapse, no device helps because iris prolapse depends on IFIS severity and pathological damage to iris stroma and muscles. So there is no credit to the pupil device when you don't have iris prolapse. It's just low-grade IFIS. So a favorable pupil expansion device in IFIS will be one which requires small incisions that will cause less leak and iris prolapse, and the one which is thin and has a low vertical profile, allows more space in the AC, and which can exit through a side port when iris may be prolapsing. Despite iris hooks, I had a frayed iris even before I had finished my capsulorhexis. The iris looks like a fishing net and I had to protect it as I inserted the phaco probe. It isn't surprising that I have a knuckle of iris prolapse through the side port. The iris is patulous and moves like the sail of a boat as viscoelastic is injected. The IOL is injected safely, but the iris looks like a fishing net and is completely frayed. Given the situation, the end result looks pretty good. And this is a short eye with a shallow AC planned for a toric IOL. And as soon as I inject viscoelastic, I note a little fluttering. So I choose to use a B-hex pupil expander, but the IFIS is so overwhelming that I have an iris prolapse to the side port as well as the main incision. Nevertheless, I managed to put in an IOL and align it, The B hex can be removed through a 1 millimeter side port, and that's a huge advantage in an IFIS situation like this. Pupil devices do not prevent iris prolapse, but they provide a constant pupil size. This is a femtolaser cataract surgery with an older generation B hex pupil expander. And here, the hexagonal pupil is seen after docking, and the pupil diameter is fixed, and the treatment is completed. The free-floating capsule is removed, and phacoemulsification is completed. And IOL implantation is again easy because of the visibility, and removal of the B hex is, as usual, very easy. And here, femtocapsulotomy and nuclear fragmentation is done with a 4.1 pupil. The error shows up because the capsulotomy intersects the iris, and an adjustment has to be made to the capsulotomy size. And now the femto treatment is completed uneventfully. The free capsular flap comes out very easily, but the pupil is too small for safe phacoemulsification. So a B hex pupil expander is used, and as the alternate flanges are tucked, the capsular rhexis is safe because of the uniplanar design of the B hex. Despite the small capsular rhexis size, phacoemulsification is now so much safer and easier. And that is the last fragment being emulsified. And similarly, IOL implantation is under such clear visualization. And removal is so easy. And we have a wonderful round pupil at the end of surgery. The B hex has been used in a series of vitreoretinal surgeries. The B hex provided good visualization for the cataract removal, followed by vitrectomy for the vitreous hemorrhage and laser photocoagulation. And this is a silicone-filled eye with PVR, where the B hex provided good visualization for silicone oil removal, followed by PVR membrane removal and identification of the break, which was in the extreme periphery, followed by a retinotomy and fluid air exchange with gratifying results. If you are looking for an easy device that allows a lot of space in the antechamber, the B hex is your go-to pupil expander. If you're looking to tear a fibrotic pupil, you will need a bulky Mulligan or APX. This could be easily done with Kuglin hooks. The choice is yours. Thank you.
Thank you.
Thank you, Dr. Istiak. Thank you so much. And actually, I lost internet connection almost 5 times through the whole presentation.
Okay, so I was just hoping that it does not happen here. So
thank you.
It's my turn now. I'm going to be start sharing my screen, and please let me know if I am visible.
Yep.
Yeah, that's all right.
Yep.
Okay. So I'll be talking on tips and tricks of iris hook in managing small pupil and IFIS. And as with all the devices and all those things that we do to overcome the small pupil and IFIS, we have to remember that the more manipulation and stretching, there is going to be more inflammation, break of blood aqueous barrier. And if the size does not come down, we will have photophobia, difficulty with near vision. So all the devices, nice devices that the investors themselves showed here, we have to think of what we want to use, the timing, whether the ports we are going to make, and how to take it out. So as I am going to talk on iris hooks, I would concentrate on this. So what are the numbers that we want to use? Where should be the location of the side ports? And what should be the position in the cornea? Like I used to do the 4 side ports, and the main incision in between the 2 iris hooks. But now I have moved to the 4 hooks, 2 at the side ports and 1 at the main incision. I will show the cause why I do that now. But sometimes I use the 5 hooks also. I am sure that this takes more times, as Professor Boris and Professor Ehud has mentioned that these hooks takes more time. This was the video that I downloaded from YouTube. And this is a trainee doing a small pupil with Irish hook, and look at the placement of where he had made it. So if it is too anterior, it's going to pull the Irish anteriorly, it's going to tent the Irish, allow more fluids to accommodate. So the trainer took over and showed where to do it. So we have to be near to the limbus. And I am going to show a video of mine that, just using the hooks, it will increase the pupil size, but it has its consequences. Like here, I did the 4 ports. While I was introducing the 4th hook, this was a hard white cataract. So there was chance of Argentinian style expansion of the capsule, and I had hit the anterior capsule with the 3rd one. But I was lucky that it did not run away, and it gave me a scope to complete the rhexis with forceps and cystitome. And I think that this was just a sheer luck. So we have to be very careful while we insert. And just see what happened. There's a big dialysis here. Maybe this was pre-existing, or because of its hardness, it was an iatrogenic procedure. And this happens with the small people, since we don't know what is behind that small people, what is the state of the, whether there is a phacodonosis or not. So this is where I like to show that, have some oozing from the conjunctiva. So it shows that I have gone sufficient posterior near to the limbus, introduce all the hooks, 4, 5, whatever number we have intended for, then hook the Irish. Don't pull it after introduction, rather introduce all the hooks first, very gently, and then pull only up to wherever we need. We should not stretch it too much. Like this is something like 5.5, I think. And I am happy to operate within this amount of space. This was a little hard cataract. And so once the hooks are in place, the pupil is dilated, I have sufficient space, and whatever techniques we have, I am comfortable with stop and chap. So I continue to do that. And with all these new machines, it was relatively easily done. And then we have to be very careful while taking out that we don't catch the rhexis margin, and take it and then give pilocarpine or whatever we are comfortable with to end the case. But as Dr. Shuven or Professor Boris was showing, that with the 4 hooks, there is a problem that sometimes the Irish comes from the main incision as fluid is accommodated there. And all the surgeon who has faced this know that how difficult it is to put these fibers back. All the rest of the part of the people will come down, but these fibers will keep on disturbing the surgeon, and it's very tough to get it out of the incision. And look here, I have put my signature, my name over here. So the people will be remembering me all through his life. So now what I have moved to, the method that Professor Boris was mentioning, that has been described by Dr. Thomas and Dr. Topes, that make 2 side ports and main incision and put the hooks through the 2 side ports and the main incision, because the Irish comes out from the main incision and all the ports that we have made. So if we pull the Irish in that direction, this prevents any accumulation of fluid. Also, it prevents prolapse of iris through those side ports. See, even after vigorous hydrodissection and delineation, the pupil is there. There is no iris prolapse through the side port or the main incision, and I could finish the case with ease and implant the IOL. And most of the time, once this is done, the pupil comes to its normal shape. This was a very shallow anterior chamber, and we can see that there has been many PI tried here. So I was doing a combined, and since that, for that reason, I could not plan my side port here. So I went for 5 hooks. Just similar thing. I'm just showing this, that if we do a 5 hook, we should put the 5th hook in the incision, and that prevents all the Irish prolapse and the different problems. Now coming to the intraoperative floppy Irish syndrome. This is a video I think I will remember throughout my life. This was a physician who had history of tamsulosin and all those medication. Just after I made the incision, Irish was coming out. We all know the cause uh, of this IFIS, know the effects that's going to be dilated poorly, iris glowing, intraoperative meiosis, and iris is going to be prolapsed. So I was in such a situation that I had to make another port. I could not get that iris back through that first incision that I made. So this was a very bad learning experience for me. So what are the management strategies that Professor Boris has nicely elaborated? I'm not going to go into that one. Sorry. So what can happen if there is a dialysis? Not that paraoperatively, this is a beautiful surgery done by one of our trainees. At the end of the surgery, the iris came out and he was trying to put it in and there is a big dialysis. So not only during surgery, also at the end of the surgery, after IOL implantation, this can be a big headache for us. And if it can occur at any moment, like on the left one, we can see that it started even after making the incision, but most of the time this happens after we do a hydrodissection as fluid goes below that part of the iris. So this is a trick that I follow myself. This surgery was done just 2 days back. So we can see that iris came out. So what I do is that with the root of that cannula, I press that iris so that it cannot come through that. And as we can see that I did 2 or 3 more hydrodissection at 2 or 3 places, but I was preventing the iris from coming out. Just the management, there are a couple of things that I can share my experience that here also it came out, iris came out. I tried to do a gentle hydro, but it was just coming out. So I stopped doing hydro and went inside with 0 foot pedal, did a central groove, tried to rotate. Usually this rotates, but if it does not rotate, this is something what I do, very gentle hydro delineation through the side port and keeping the probe in the incision. So there is no scope of the iris to come out of the main incision. And we could see that it was rotated then, and I could finish the case after that. And this is a video that I want to share that we can use iris hooks even after the rexis is done. Here, once the rexis was done and I did hydro, iris was coming out from the main incision. And I decided to give iris hooks there. So gently tapping the iris, getting the fluid below that, then made 4 hooks. That time I was doing 4 hooks. Now, if I do 4 hooks, I would have given 1 in the main incision. But one point I want to make sure that if we insert iris hooks after the rexis is done, we have to be very careful that we don't hook the capsule. So we should put OVD at that site where we want to hook the iris and be very careful to see that we have gone above the capsulorhexis. So take my time and do that. So once this is done, then it's easy. And I want to just emphasize on one thing more, that sometimes what we do that whenever we're in problem, we lift the bottle height. But now with the new machineries, we know that what is the IOP, and there is more fluid. Like here, if we put nearly 90 bottle height, the IOP is 60. But in these cases, we should go down with the fluidics. So the take home message would be, we should take very careful history, do very carefully preoperative evaluation, plan how we want to do, and we should have all the gadgets ready and counsel the patient that this can happen and this is a complicated, so the patient also knows that. So thank you all. I thank everybody for the hearing. Okay, so thank you for the patience hearing. Now I invite Dr. Thanapong to share his screen. I think he's going to be presenting on uveitic small pupil management. For us, it was just that perioperative, but cyst also goes on after the operation. Dr. Tanapong.
Okay, thank you, Professor Iftik, and thank you all the organizing committee to invitation. Today, I'm gonna talk about the uveitis small pupil management. This is my financial disclosure. So I'm gonna go through the introduction, a little bit on pre-op evaluation and small pupil in uveitis, how different in uveitis compared to the IFIS or another kind of the small pupil cases, and the summary. So let's start with introduction. I would like to start with this. Uveitis is not a single disease, but it is a group of diseases that share common characteristics with its intercellular information. How this is very important, because when you see the uveitis cases, the prognosis is not the same, the communication is not the same, it's not the one diseases. Also, like the small pupil cases that you want to go for the cataract surgery, you might want to manage the patient respect to the outcome of the surgery. And I would like to emphasize you again that patient and JAA, you may need to really control the information at least 6 months before the surgery. So in uveitis, you can say the cornea can be like poor visualization. You can have the band keratopathy, very low cell count. Chamber can be very shallow, peripheral anterior synechial, a lot of ideal corneal adhesion like you see here. The lens can be vary. It can be soft, hard, mature, can have rhabdogenesis, poor sonar support, or even have the anterior capsular fibrosis. But topic today, I'm gonna focus more about the pupil. Sometimes it can be like this. It's very small, almost no pupil, posterior synechial. Eyelid atrophy can happen in many kinds of diseases. Floppy eyelid width is really important. If you do the surgery much more, you're gonna say small pupil is not the real problem, but the floppy eyelid is much more cause of the complication. Another thing that can happen is pupillary membrane, and it can have like the NVI, it can have fragile vessel there that might bleed when you manipulate the eyelids. So before we go for the video for the management of small pupil, I would like to emphasize all of you about the pre-op evaluation, which is very important because the inflammatory and IMP control is the key. Successful surgery can be like go to be nightmare if the inflammatory not controlled. The day, 2 days after surgery, you can have really bad inflammation. So time for cataract surgery seems to be like 3 months with the well-controlled inflammation. And this is not the magic number because of actually we have the evidence that if you control the inflammation well, 3 months or more, that can reduce the most common complication post-operatively, which is the CMA. IOP control is another thing. It depends on mechanism because sometimes the lens itself causes the inflammation. That way, you might not want to wait too long. You control the IOP and you go in right away to remove the lens that caused the IOP lysing. Normally, it's recommended to control at least 2 or 3 weeks before you put the patient to the surgery. And some anti-glaucoma can cause inflammation and also risk of CME. If you can, you might want to avoid cholinergic medication or prostaglandin analog. Another thing is antimicrobial prophylaxis, which is controversy with limited evidence. But 2 of them is the toxoplasmosis that you might want to do, Bactrim before, or the viral anterior devices that I show on the screen that you might want to use the antiviral just 5 to 7 days before and after the surgery. Okay, so we move on the surgery. As we know, I'm gonna show out sometime like on the right hand side, they have the difference between the small pupil in the normal case and in the uveitis case, and how is it different? They have 2 or 3 or 4 steps that different. One, because of uveitis, most of the time they have the posterior synechial. The way to do synechial is different. And we also have the phimotic, interpupillary membrane, and we have the many ways to make the pupil big enough to do the operation and some special concern. We start with the synechial lysis. Sometimes it's very easy if you go with a blunt tip cannula and just use it to lysate the synergy. You can go to the side port, main port, you can make another side port, go in another way and use the viscoelastic with the blunt tip cannula. I do personally prefer the dispersive, the high molecular dispersive viscoelastic that have the very good weight to put the retina down. And after you lysate the synergy, you can use the viscoelastic itself to do the viscodilatation. One well-known technique is use the simple set with bimanual set with whatever you like, Cocken, Leicester, whatever, and you do the viscodilatation. Note if you see there in the video, you can see some breathing from the fragile vessel. And right now we have another thing that can cause less breathing and less inflammation. Another trick is you might want to avoid the viscoelastic that you put underneath the eyelids when you perform the posterior synergy lysis, because that will cause another chance to have the Floppy eyelids go through the wound during the main part like this. If this is when I do hydrodissection, you're gonna say the eyelids go through the wound, and this can cause another eyelid atrophy and trauma to the eyelids. Another technique that normally I'm stopped doing now is do the sphincterectomy, because if we do that, they can cause bleeding, they can cause like more trauma to the eyelids. But if you have the very thick membrane at the pupillary margin, this can be the option. You can set it after that, and you see the pupil turn out, and the shape is different, and you do the viscodilatation after. The second thing is the membrane management. As I talked before, a lot of UVT cases have the posterior synergy, and you can have like the interpupillary membrane at the pupillary margin around the eyelid stroma, and this can cause bleeding and eyelid prolapse. Sometimes you just remove the membrane, easily remove it, and that can, the pupil can expand nicely with the viscodilatation. And please be sure that don't do too much aggressive stretching the membrane, because that can get bleeding, and sometimes in the very hard cases, it can cause iodolisis. Sometimes the membrane can be very thick like this. If you see on the right hand side, you're going to see 2 layers of membrane in the interablative OCT. And I use the capsulexis forceps to remove the membrane first before I go down to do the real capsulexis. So when we do this, you might need to use the forceps, because if you use the cystosome or the needle, that can cause the damage to the capsule underneath it. Sometimes the membrane is too thick like that in that area that I moved the OCT there. You can try to remove it, but if it's too thick, you might want to cut it or leave it, because if you do too much stretching, it can cause more damage to the anterior segment of the eye. And after that, we do real capsulolexis there. The third thing is to make the pupil big enough. Today, you already heard a lot of panelists that have the very good video experience way to dilate the pupil. One point I would like to point out is when you do the eyelid hook, don't pull it all the way. You gently put it 3, 4, 5, whatever you want, and gently adjust it when you put all of it in the eye. That's gonna help less trauma to the eyelid border and less bleeding. And sometimes the eyelid hook can be held like this case. We have the phacodonesis, and eyelid hook itself can use to hold the anterior capsule. You remove the hook from the eyelids and hook the anterior capsule, and you can provide, you can perform the cataract surgery, the phacoemulsification with that. Another thing is not only the eyelid hook, but the capsular hook is also helpful in the case like I showed before. Another thing is so many good kind of equipment like the Mayukin link that I like to use it. BHAG I would like to try. APX maybe in the future. I really want to try this. This is the nice way to expand the pupil, and it's also help with the IFIS too, like this one. The first is some special concern I would like to point out. It's very, very important, even in the very small pupil, to remove all the lens material out. Because if you leave just a little bit of it, it can cause inflammation for a year or more. So if the pupil is small, you might need to the second instrument to make sure that all the lens material is removed. Another way is just put the equipment in, iris hoop, Mayugin, BHAG, APA, whatever that you like. And last but not least, listen interpretive post-op care is very important. You can, most of time now, I use the intercameral beta or dexamethasone that's gonna live only 24 to 48 hours after the operation, but that should be enough for you to control the inflammation post-operatively with a systemic medication. And intercameral antibiotic can be concerned. And really important, not just intraoperative small pupil management, but long-term regular and listenable prevent post or follow-up with prompt treatment are very essential to deliver the outcome to the patient. So in summary, uveitis is not a single disease, it's a group of diseases, same as the cataract surgery in uveitis in the small pupil. So not just know your patient, not just know the patient eye, not just perform the cataract surgery, but you have to know your patient, not only the eye. Perioperative inflammatory control, both IOP and IOP is also a key. Manage small pupil in uveitis is a state of art to deliver the best possible outcome to the patient. And thank you again, all the audience and all the panelists. And thank you again to give me the opportunity to say hello from Bangkok, Thailand, and present this topic. Thank you.
Great talk, Dr. Thanapong. That was excellent. Can you stop sharing your screen, please? Okay. So now it's time to bring the panelists. We have a great team of panelists. I would just introduce our panelist, Dr. Nazrul Islam. He is a professor at Bangladesh Eye Hospital and Institute. He is a great cataract and refractive surgeon. He is the current president of Cataract and Refractive Surgeon Society of Bangladesh. He was the past president of Bangladesh Glaucoma Society. He is board member of Asia Pacific Glaucoma Society and chair of the board of director of Joshua Eye and Laser Center. Dr. Lee Moon Wai, he is the medical director of LEC Eye Center, Malaysia. He is a fellowship trained VR surgeon and excellent cataract surgeon. He has done live surgery in APS CRS, and those who have done live surgery in a conference knows what a tremendous pressure he is. I was a audience in that. He's an excellent surgeon. He has got more than 20 publications, and he's a reviewer for ophthalmic journals. Dr. Shamaresh, he is a consultant at the Rogodip Eye Hospital in Jaipur and Ahmedabad, India. He has a knack of producing ophthalmic films, and he has bagged many prizes for that. And in 2015, he won the grand prize for his Strange Stories, Amazing Fact, the Webfront Omnibus for that film. He is an associate editor in cataract and refractive section of the India Journal of Ophthalmology, and he is reviewer for many journals. Dr. Khair Ahmed Chaudhary, he has done his fellowship from Glasgow, and he's an associate professor at National Institute of Ophthalmology, the Apex Institute in Bangladesh, and he's a fellowship trained pediatric and phaco surgeon. So I would invite them all, and I would request Professor Nazrul to start any question and comments to the speakers, please.
Thank you so much, Ishtiaq, and thank you for your kind words. I think it was an excellent webinar, and we'd like to thank all the speakers, Dr. Boris, Dr. Asia, Dr. Suben, Dr. Thanapong, and you yourself. All presentation was really, really nice. And I was feeling the inventor of three pupil expansion device, the Malugin ring, BHAX, and APX. All the inventors are the three international stars, and they are sparkling in the sky of Bangladesh now. We are so happy. And Dr. Boris already told that she wants to come to Bangladesh. Already you have come to Sky. Probably you will come physically in next time. Definitely, we welcome you in Bangladesh, all of you, including Thanapong. Thank you very much. I think I'll ask one question first to Dr. Boris. You have a lot of question speakers, but I'll go a bit different. A general question to Dr. Boris. If you find a small people, an IFIS case, we become stressed, we become in tension. Whoever maybe senior surgeon, maybe a junior surgeon, we become stressed. So what are the tips you can give to reduce the stress for a surgeon? You got my point? Please unmute. Okay.
Thank you, Dr. Islam, for your nice comments. I think the stress is definitely what we experience in our surgeries, and no matter you experience one or not. But obviously, the stress, the level of stress decreases when your experience increases. So I think the best way is to be trained and to continue what you're doing, and with more experience, with more surgeries, I think the level of stress will come down. However, even I believe you and me sometimes have stress during the surgery when the things are going differently from what we expected. And we have a nice symposium last year at ESCRS, which was called How to Control Stress in Surgery. And there was one world champion of diving underwater who was having a world record of Guinness Book, how to dive under the ice. So he was sharing with us some kind of insights, how to calm down, not to panic, and stay cool, and try to not to make too excessive movements, because when you start doing something uncontrollable, this is when you're losing your energy and a lot of resources. So, and that should be avoided at all costs. I think the best is to sit, take a deep breath, think a little bit, and then to continue.
Thank you very much. We have another question, but I will do later on after all panelists talk. Definitely. Thank you, Stiak. I think other panelists should.
Dr. Lee, what is the commonest device for that you use in Malaysia?
Well, thank you, Ishtiaq. So again, I think just like what Dr. Islam said, again, it's a very privilege actually to be amongst, the inventors and such innovators here. And basically, I think small pupil management, as you say very aptly in your title, the pupil is small, the problems get big. So I think in Malaysia, fortunately, personally here, I don't see as much IFIS as, the Caucasian population, but we still have it. And I fortunately have access to the Malaysian ring. I think I've tried the BHEX once and IRIS hooks, not tried the APX. Dr. Asia, I would love to try the APX as well. But at the moment, I fall back on my IRIS hooks a lot of the time. I find that they're very versatile. So no doubt there are advantages and disadvantages with all devices, but I still use the IRIS hooks more often than not at the moment. Actually, I thought we might cover a few questions because there were a lot of questions coming in. I think perhaps each panelist can take a couple of questions. That's all right.
Summarize, what are the questions you have picked? Please ask the speakers.
Yeah, I think Dr. Mal-Eugene, I think there were a couple of questions about from the attendees actually. So I thought maybe we would cover that. Just relating to IFIS, whether, in terms of stopping tamsulosin, how do you do that and how much before? And also a mention about mannitol and its usage for the prevention of IFIS. Perhaps you could comment on that.
It was shown that there is no reason to stop tamsulosin because the damage to the iris is irreversible, and it starts 2 days after the beginning of the intake of the medication. So there is no reason to do that at all. With regard to mannitol, I think it should be reserved to cases with where the high pressure, intraocular pressure, either expected or happens. But in IFIS cases, at least in those that I have, there is no association in between glaucoma and IFIS cases. There was no proof. There is an association of gender, age, hypertension, and shorter eye, but not with glaucoma. So I think that mannitol is not very useful in these patients.
Thank you.
Bring Dr. Shomoresh.
Nice.
Yeah, so any
Yeah, I hope
questions?
you can hear me. Yeah, so I had a question for Dr. Asia. We are used to you performing, most of us, at least in India, used to performing the bimanual IA using the 12 and 9 o'clock, incisions, and that is exactly where the Asia's expanders have been placed. I would love your take on whether we could just move it, a couple of clock hours to maybe 10 and 4 o'clock, and will that interfere in the placement and the surgery thereon, or will it be just as good as placing them where you've placed them?
Well, no, the placement of the APXs can be done actually anywhere. You can move it a little bit to the side, and it does not need to be necessarily at the 3 and 9 position. You can do it actually, as I showed, I skew it a little bit. All right, if you skew it a little bit, instead of having a rectangular, you get a trapezoidal shape, which makes it easier. You can go temporal side. So if you know where you want to have your instruments go in, then you can plan and have the devices and move it a little bit to the side. Of course, there's a limitation to as much as you take, but it does work, and you can have quite a flexibility.
All right. Thanks, sir.
Dr. Khair, can you hear us? Can you unmute yourself, Dr. Khair?
Yeah, Dr. Ishtiaq, I'm here.
Yeah.
I can hear you.
Yeah.
So it's a very good presentation. I must congratulate all the speakers. They have taken pain to elaborately describing the newer things to us. So I have a little bit one question for Dr. Asia, that this APX can be used in case of a phakic patient in congenital cataract. As I'm a pediatric ophthalmologist, actually this is a generalized question for all the speakers, but I will specifically ask to Dr. Asia that device APX can be used in case of secondary IOL in a phakic patient in congenital cataract after.
Could you understand correctly? You asked if we can use it also for pediatric cataracts. Is that the question?
Yeah.
Yeah, it can.
For secondary IOL. At the time of secondary IOL, can we use this device?
Well, it can be used for either primary IOL or secondary IOL. It doesn't matter. But yes, we do, and we did a few cases also for small eyes. And we did also cases, for example, non-ophthalmos. Non-ophthalmos eyes like 18.9 or 18 or 7, even I think the smallest one was 17.5. And that was very small eye, very shallow chamber, and still we could insert the APXs. So yes, it can be done also in eyes with pediatric cataract.
What is the height of that APX device, Professor Asia?
The 8?
Height.
It's like I think it's 0.4 millimeters, or so 0.4, 0.5 millimeters. So it's
single time use, or there's a possibility of using
it is disposable. Yes, it is. Yes, it's mandatory to be disposables because by the way it's manufactured, you cannot guarantee that if you realize it, it will be exactly the same strength of the spring every time. So it needs to be. It is at least designed to be disposable.
Okay.
It can be used
Dr. Asia, from the attendee, Dr. Kamrul Hassan Khan is a great phacosurgeon. He has asked you, Dr. Asia, that if you use your APX, is there any leakage, any significant leakage during phacoemulsification that may cause AC stability difficult? Is there anything like that?
This was the point. This was a very significant point once we designed it. But what we find out that because it opens up and stretches, it goes actually occupies the entire incision. So we do not see a significant incision. Also, I'm very much in favor of working with anterior chamber maintainer. I do not work much with viscoelastic, with OVDs, and I work a lot with anterior chamber maintainer, meaning that I'm using fluid not only for the phaco itself, but also in between, so to manipulation and even the implantation on the fluid only. And still it's not a problem. So leakage is not a concern.
So another question from Dr. Farzana Sharmin to you also, that in case of shallow anterior chamber, can you use your APX? That is, BX can be used. Dr. Suben has showed you that BX is easily can be given because shallow anterior chamber is very thin. So what about the APX? Can you use it?
If I can you see my screen now?
Yes,
Yeah,
I can see, yeah.
Good. Okay, so I will ask you answer with the simplest answer. Here's the case of an ophthalmos, which I just discussed before. This is a very shallow anterior chamber. This is a patient with an 18.9 millimeter, and here I'm using the APX, and still there's a lot of space for the.
Your video is not coming. Your video is not showing.
Yeah,
Oh,
Dr. Asya, I think you have to share it again, I think, because we only
We can
seeing
see your screen and we can see the folder, but we can't see the video.
Yeah, double click over the video, it will come.
You need to actually open the video first and then share screen.
Yeah.
Well, okay. I see this.
You have to stop sharing and share again, I think, Dr. Asya.
You have to stop sharing, open the video, and then start sharing.
Okay, let me see if I can do it. I will try to do it once again. I'm sorry for the time. Anyway, but what I would like, I would show you that we do it in the case of nanophthalmos, small eye, and it's not much of a difference. You can see there's a little less space, but once you use OVD, when you put in the APX, it's not a major problem. I will try to show you if possible. If not, just trust me and I can send you the videos. But nanophthalmos, even in nanophthalmos, less than 90 millimeters and shallow anterior chamber, it did work very well.
One question for Dr. Suben from attendee,
Yes,
that definitely we congratulate you. In the developing world,
thank you.
Your device is very cheap. Sometimes our patient cannot afford the Malungin ring, the Visitech eye ring, very expensive, more than $100. So it's only $20, $30. So our patient can afford it. And definitely it's very good device. Congratulate for that.
Sorry,
So
I've lost
is
you.
your device can be usable for a very rigid people? If the people is really rigid, say 2 millimeter, 1.5 millimeter, pseudo exfoliation syndrome cases. So can you ease your device in that cases too?
Yes, to answer your question briefly.
Dr. Suben, just before you answer, I just wanted to ask, something similar to this is that, what is the mechanism, because it's so soft, it can come out from the side port and so malleable thing, how it resists the contraction of this pupil and this thing? A similar sort of question.
Okay.
Especially rigid people, especially rigid people.
Yeah. Yes, good question. So to answer your question very briefly, it can be used for any pupil. Okay, so now, as I said, we need to understand that there will be a rigid pupil and an elastic pupil. So when it's an elastic pupil, even if whatever the size, it doesn't matter. If it's even a 3 millimeter pupil, if it's elastic, it's like a rubber band, which will stretch. So the BX is strong enough to stretch it. If it's a fibrous pupil, it's like a string. You cannot stretch it. It's going to tear. So what you choose to tear, the pupil margin, is up to you. If you want the pupil expander to tear the fibrous pupil, the BX will not be able to do that. Okay. So to use a BX in a fibrous pupil, you will need to use a pair of Kuglen hooks to stretch the pupil, and then to about 4.5 or 5, and then use the BX. You could use the APX very easily because it's a pretty strong device. Even the Malungin ring, the older version of the Malungin ring was stronger. The newer version is slightly, it's a thinner gauge proline. So that's the trade-off. So if you want a thin device, it's not strong enough. Now, to answer Dr. Istiak's question, well, the BX is made of polyimide. It's not polyamide. Polyamide is nylon. Polyimide is one of the toughest plastics on earth. So it's a flexible plastic. So that is what gives it the unique advantage of being a very thin profile. It's 75 microns. It's thinner than our natural hair. So it's that thin, and it still has the strength to stretch a pupil. So that's to answer your question. I'll be happy to answer anything else.
I have a question for Dr. Tanapang that when do you give systemic steroid for this uveitic? Is there any indication that you preoperatively start? Because some of our colleagues here, like to start preoperatively, maybe 1 day or 2 days earlier when they are doing this sort of small uveitic people.
Okay, thank you for the question. So as I said before, because of the uveitic difference, so we have the evidence that if you use the systemic steroid 5 to 7 days before the surgery, that can help with post-op inflammation. But it really depends on what kind of the uveitic cataract that you have. And you can also do the intravitreous or intracameral dexamethasone just at the end of the surgery. That will help too. So it's no perfect answer for this. For me, I do prefer a lot in bed chat, which is really need to control the inflammation before the surgery. Yeah, thank you.
Dr. Shamoresh, you do a lot of flex, femtolaser.
Yes.
So do you do use, I mean, in small people, any of the devices?
So, Ishtiaq, for us, I've briefly used a few of the devices, but my device has always been a Greischeber hook. And why I'm saying a Greischeber, because in terms of iris hooks, that I feel is the most pliable hook and it doesn't cause as much damage. But I've never implanted a ring and then taken the patient back to the flex to fire the laser. Although I saw a very elegant surgery shown by Dr. Suven, and it is a fair possibility. But my choice for up until now has been iris hooks for all my small pupils. I do understand now, after having listened to Solberts many times over, that cataracts like dislocated lenses, subluxated cataracts, where I normally would use hooks to stabilize the bag and then use hooks to dilate a pupil if it's small, means a lot of ports all across the eye. And maybe in those eyes, ring, either a BHEX or a Malugan ring, which does not involve too many incisions, placement and making, may be a good idea because you can keep the eye that much close and you can use the other incisions for, approaching the complexity of a subluxated lens easier.
So I have a question to Professor Boris. That do you ever use other devices to also Professor Yehudasia and Dr. Shuven, that apart from your devices, are there any situations that you would go to any other devices?
Boris, you need to unmute yourself.
Yeah, I did. Thank you very much. I get used to the ring that I designed, and I tried all the other devices on the market, each and every one of that. And I found them useful because all of them works. However, I have my personal preference, and I think it's obvious because every surgeon has its own preference. His speco machine, microscope, instrument that he loves, lens, and so far and so forth. So I think whenever you get used to the instrument you are comfortable with, so then you stick to it and then continue. So I don't want to criticize other instruments or emphasize the benefits of my instruments. I think people, you can see from the videos and from the talks. So my recommendation is to choose your device, get used to it, and use it. And I think that is the most important. What I really cannot understand is why so many people are still using hooks. Because I think there's a 50-50 separation. So 50% of people are using hooks and 50% of the surgeons are still using rings. So that is a little bit strange to me because I think the rings are better. For certain cases, hooks works well and the ring cannot be replaced by hooks. But in the majority of cases, I think in 90% of cases, I think every problem can be solved by the ring. But I think it's a matter of tradition, a matter of what technology person is. get
For
used.
our case, Dr. Boris, we don't have any. It's not available here. So whenever we go to
Yeah,
conferences like AOA or APSCRS, we
No,
will get all these things. Yeah.
I'm not talking about you because if you don't have choice, this is another story. But I'm talking about the countries when it's available, and it's still the division by 50-50. So that means that surgeon may use this or that, and he is not having any economical or accessibility issues. But still, there is a kind of half and half. So,
Yes. So let me pick up from where Boris left. So Boris, the take-home message for us, you, Ehud, and me, is that we have to work a lot harder to convince people that the rings are always, or pupil expansion devices are better than the hooks. Okay. Now, to come back to, I think it's more because of, we have an inherent tendency to think, okay, the hooks look simpler. So it's a kind of something which plays in the back of the mind that, well, that's going to be simpler and easier. So if I'm going to have a tough situation, I'd rather play on something, bet on something easier. Well, that may not be the case, like Boris was saying. Once you get used, or Ehud's design, or for that matter, BX. So whatever device you get used to, you could handle the most challenging cases with that once you have an understanding of the device. Now, I have had the opportunity of using the Malugan ring, and definitely it is a game changer. There is no denying. Boris is a good friend, and we've learned a lot from him. He has led the way to show us that was a paradigm shift when Boris brought in his Malugan ring, and I was working at the same time. So I was using his device, and then, of course, when I started working on mine, I had to spend a lot of time on my device. So then, of course, that usage came down. Uh, what I have been trying to campaign for is, irrespective of the device, whether it's hooks, Malugan ring, the ACR pupil expander, or the BHEX, I think surgeons world over need to reduce their threshold for using a device. We have a tendency of postponing and saying, okay, let me just see, I might just go beyond the capsulosis, I might just try it. I think we need to reduce our threshold because the patient's expectations are on us, and it just takes a little more time, a little more expenditure, but saves so much of trouble, and it's so much risk-free and safer for the patient. Premium lenses, you can't afford to take a chance. For that matter, any eye, you can't afford to take a chance. So that would be my message to everybody. Please reduce your threshold for using any device that you choose. If it's IRIS hooks, so be it.
Dr. Shubhan, similar to this, I have a question to you. I think to all the inventors, that if a patient having, say, 3.5 to 4 millimeter pupil, 2 to 3 plus cataract, with all viscodilatation is not possible to dilate, what is your choice? Will you go directly to phaco, or you will use any device? My question is, it's up to 4, not more than that.
So, like I said, we have all been very heroic surgeons. You are from a time you started surgery much before me. Boris Saib, Ehud would have probably started a little earlier. So all of us, before IRIS hooks were available, we have all done all the heroic surgeries. When IRIS hooks became available, initially Grisha hooks were very expensive. When the Prolene hooks came, they become more affordable. So we moved through the hooks. So I would recommend that since now devices are so easily available, they are so user-friendly, there is no reason to be heroic. What would you like in your eye, sir? If you have a 4.4 millimeter pupil, what would you like your surgeon to do? Would you like him to try a heroic surgery, or would you like him to be safer and dilate the pupil and be... See, it's not the size of the pupil to start with, it's what we are worried about, the pupil coming down. If I tell each one of the surgeons over here that you're going to be given a 5.5 pupil, and that pupil is not going to come down, everybody is happy to do the surgery with the kind of fluidics that we have now. So we need a assured pupil size to perform the surgery for our peace and confidence.
So this is a question, common questions many have asked actually, that if there is a 4 millimeter pupil, would you directly start with the devices, or you try and then you see that it's coming down, or there is IFIS, then you go for it? So yeah.
Dr. Asia, want to say, Dr. Asia.
Yes, please, if I may answer. And I also would like also to echo what my my colleagues have said about all the devices that we have now. We have armamentarium of options. It's not just one option. We have a lot of options now that we can use, and I would recommend to any surgeon who is practicing cataract surgery to try them all. If you don't try them all, you don't know what they are. If you ask, do you use other devices? Yes, I do. I do use other devices because I want to learn and to see which one is best for me. Now, as for the question of for the 4 millimeter pupil, would you go for pupil dilation or not? It depends. If you have, for example, if you do a femtosecond laser and you have a capsulectomy already, the nucleus is cut already, and now the pupil is coming down, it's another situation than when you start with a small pupil. If you can easily cut and you can and you have small pieces, it's very easy to move all these pieces with 3 millimeters. It's not a problem. So if you have even 3.5 millimeters, but all the pieces are cut, then you can take them one by one easily. If you need to start the operation with a 3 millimeter, it's much more difficult. I do agree, surgeons should work in its safety zone. If you are a novel surgeon, don't take any chances. Dilate the pupil as much as you like in any case. If you feel more comfortable, then you can try to move and then working with a smaller pupil. Once you have a problem, dilate it up and use armamentarium of options. There are so many ways to do it, and there are many ways to overcome problems. And again, going back to what Boris said at the beginning, the way is out not to panic. Most of the problem and most of the complications occur because of panic, not because of complications, not of bad situation. Every bad situation in the eye as a way to overcoming and to correct it. The problem is when the surgeon panics and he wants to finish the operation and close everything up, this is where problem just starts.
So I have a question of myself that Professor Boris or all the panelists, that sometimes there are small people that don't prolapse, and there are sometimes 5 or 6 millimeter pupils that start coming down and prolapse. Can we differentiate this preoperatively? Are there any tricks that slit lamp or history or by something that we can pick up?
Well, my experience is that if you have a patient who takes, for example, tamsulosin, but you start with a large pupil, usually a large pupil to begin with is less constrict than when you have a pupil which starts with a small pupil. If you start with a patient with alpha-1 antagonist and the pupil is 5, you will probably end up with 3 and floppy iris. So this is one thing. The other thing is always in these cases start with injection of lidocaine and adrenaline into the eye. That helps a lot, but it's very, very difficult to predict. The time when the pupil comes down usually is the time of irodissection. This is the stage when you start to think the pupil comes down. If it does come down during irodissection, then be careful. Don't start the phaco before you dilate the pupil.
Yes, Professor Nazrul.
A question to Dr. Tanapong. Dr. Tanapong, I'm also a glaucoma surgeon. So after trabeculectomy, post-trab cases, we find very frequently that AC is very shallow, cataract is very hard, pupil is irregular and small. You cannot go in the entry chamber. How do you manage this kind of cases?
Actually, thank you for the question. That is really important. So for myself, I'm gonna try to enter the chamber with the same thing, same procedure with the 1 millimeter blade. But if I really can, I'm gonna take the advantage of the vitrectomy. I do the vitrectomy first.
Yes.
And then, try to enter the anterior chamber later. But for the because we are the posterior segment surgeon, but if you are the anterior segment surgeon, you need to really go through the anatomy, not to do any trauma to the posterior segment. Yeah, that's it, my point.
But we have learned it. Our posterior segment surgeon, they have helped us to learn up to this. You can get a little vitrectomy you can do by using a trocar cannula, and we have learned it. And I have done some cases. In my glaucoma cases, I have to do like this. And in these cases, I could not use the devices. I had to use the iris hooks because it is so shallow. So iris hooks is the real friend at that time, as Stiak showed.
Totally agree. Thank you.
Dr. Shamaresh, do you use atropine preoperatively? Because in some cases there has been report that it can cause acute urinary retention. So whether it helps and how do you judge the benefit and the...
It's a question from attendee also that can you use atropine preoperative or perioperative in this sort of small people cases? So I think the same question.
So for us, like in our clinic, we are using cyclopentolate as our drug of choice. We don't use atropine because of its side effects and its problems, but we start the patient on cyclopentolate 1 day prior, and even on the day of surgery, we ask the patient to put cyclopentolate twice in a required time frame before they enter the surgery. But we're not using atropine in our clinic.
Yes, Dr. Lee. Unmute, please. Unmute, Dr. Lee.
Yeah, sorry. Yeah, I just wanted to ask maybe the panelists or the experts here, because I think we're talking about pupil management, a lot of manipulations to stretch irises and all that. You showed in some of your videos, Ishtiaq, about how the iris does prolapse. Is there any tips or polls to some of our other colleagues here to how to manage iris prolapse? Because sometimes we find that shoving it in or putting more viscoelastic, it doesn't really help. So perhaps tips from Dr. Suvin is raising his finger there. Iris prolapse, yes.
Yeah. So like I said, I think it must be understood that iris prolapse has got nothing to do with the device. It's the severity of the IFIS which is going to determine the iris prolapse. Like Boris was saying, that it's a pathology. It's a permanent change in the structure of the iris. It's become thin. So whatever fluidics we use, it has to be a low fluidic parameters so that you don't have too much of billowing of the iris, which has a chance of moving. And of course, long incisions, which are standard things, which are long incisions and small incisions. But when the iris prolapse is happening, it's not because of your device or your surgery. It's because the IFIS is severe. So with the same device, you might have iris prolapse in one case, you'll not have iris prolapse in another. So that is something I think you might have a good day one day and say, oh, this is a wonderful device. I didn't have iris prolapse today. Well, the next day you'll have iris prolapse because the IFIS will be more severe in that other case. So that's something I think we must all realize. It's nothing to do with the device. Over the years, I've realized, at least in my hands, with the same surgeon, same setting, I mean, how can you have same incision size, same fluidics? Sometimes the iris prolapses and sometimes it doesn't.
I think it's very important to understand.
What I personally do in my cases, I use the iris hook in these cases. If there is a prolapse, I try iris hook in the other side. So that actually helps in some of my cases I've seen to finish my phaco. That I used iris hook in these cases.
Yes, Shamaresh.
I think it's very important to understand that apart from devices, OVD is also a device. And I use dispersive OVDs, Viscode particularly, because it's a high molecular weight dispersive, because the iris prolapses when there's an incision leakage, most likely. So like Dr. Suvin said, keep your parameters low. But whenever you're about to enter the eye, I put some Viscode sub-incisional to push that iris down and then I enter. And once I'm coming out and I feel the iris might come out, before I pull out my phaco probe, I inject Viscode from the side port under the incision, push the iris back and then take it out. So using an OVD smartly can save you a lot of trouble, particularly dispersive OVDs.
I have a question.
I agree with that.
Yeah, Dr. Boris, can you hear? Yeah, unmute please. Yes. So if there is a iris prolapse, would you try to continue it or immediately, use the hook? What is your advice to all the surgeons? Because I myself, sometimes feel that I should have used it, or I did not need to use it. So what is your advice for that?
Iris prolapse can be a sign of various issues during cataract procedure. And sometimes it is associated with IFIS or small pupil. Sometimes it is associated with the poor wound construction when it's too short and too close to the iris root. Sometimes it's a sign for more significant complications, such as choroidal effusion, hardening of the eye, or aqueous misdirection syndrome. So I think there is, first of all, a recommendation to find the reason why the iris starts to prolapse. So if it's IFIS, okay, you go with the hooks or you go with the rings, and that's okay. If it's poor one construction, so I don't recommend to do it, because I think you need to create another wound or suture this one. But if it's a more severe problem, such as choroidal effusion, so with hardening of the eye and so far and so forth, so it's a completely different story. And of course, you don't have to go with the hook in this case or with the ring, because it will not help. By the way, there is one publication of, from 2 British surgeons who were experienced suprachoroidal hemorrhage during the cataract surgery with the Malugin ring inside the eye. So what they did, they left the device, they sutured the wound, and then after 1 week, they come back and finish the surgery, remove the ring, inserted the IOL, and the eye was quiet. And during this week, there was no problem. So this is, of course, very anecdotal report. It is published. You can find it in the literature. But obviously, in that case, the ring did not help. But I'm glad it did not harm at that moment. So that was a good news. So iris prolapse are different. So you can behave and should behave different.
Malugin ring is an implant, actually, right?
It used to be a temporary implant. Yeah.
But one of the
off-label use.
Absolutely off-label use, but I understand the surgeon, because he was having a shallow chamber, rocky, hard eye, so, and he was very cautious to go in and to try to remove the ring. So I think it was a good decision. And
Absolutely.
Yes, and if I can add that.
Yes.
If I can add,
I'm not sure it will happen with APX, because there will be some kind of stuff outside of the eye. So, but I think it will be much easier to remove with that.
It cannot happen with the APX, because it is supported from the outside. But
yes,
that's one advantage. What I would like to say that regarding iris prolapse, sometimes it's not too bad. Sometimes actually when it prolapses through a small paracentesis, it actually stabilizes the pupil, and it even expands it a little bit. So sometimes having a prolapse can be actually help with some intraocular manipulation. So if sometimes I do see small prolapse, if the pupil is good enough, I even leave it there, continue with the operation, and just after the implantation, put the iris back in. Sometimes it can be a good idea.
Dr. Khair, can you hear us? Any other questions or comments from the panelists?
I want to make a last question to Dr. Boris.
Yes.
Dr. Boris, in the market, you have both generation 1 and generation 2 Malugin ring in the present. So is there any indication of generation 1 to use in any cases, or you can use generation 2 in all cases?
I think that the first version is more stiff, it's more hard. So it works very well with uveitic pupils, the pupils that are small and fibrotic. So because actually by expanding it, so you can easily stretch it. While the second generation, it's more pliable and it's soft. The good thing, it can come through sub 1.8, well, sub 2 millimeter incisions, actually 1.8. So it's quite atraumatic. However, I believe the second generation works much better for the IFIS syndrome, because there is no need to stretch the iris. You just need to hold it gently in place. So I think, so depending on what kind of patients you have, I think it's better to choose. And there are also 2 sizes, 6 1/4 and 7.
Yes.
So again, 6 1/4, my preference to have in fibrotic pupils, because you don't want to stretch, because when you break fibrosis, so we actually break the sphincter in most of the cases. So you don't want the sphincter to be very damaged. However, in IFIS syndrome, bigger one is better, because you don't want, so you don't worry about breaking the sphincter. sphincter is elastic and there is nothing to be worried about.
Got it. Thank you.
So I think we had a great discussion, great presentation. I thank all the speakers, Professor Boris, Dr. Tanapong, Professor Nozrul Islam, Dr. Shuven, Dr. Mulin, Limun Wai, Professor Asia, Dr. Shomoresh, Dr. Khair. Thank you for accepting the invitation, and I invite all our audiences that next week on Saturday, we have another great session of webinars where Professor Basavada, Professor Chi Sun Fake, Professor Mare Joseph Tasiknan, and Dr. Sergio Canabrava will be here. So with this invitation and thanking you, I would like to conclude this session. Thank you all for joining.
Thank you. Thank you.
Thank you.
Thank you very much.
Thank you.
Thank you,
very much.
everyone. สวัสดีค
Thank
รั
you,
บ
Ishtiaq,
สวัส
for
ดี
the
ครับ
organize. Thank you.
Bye-bye.
Thank you.
Bye-bye.
Thank you,
Sawadika.
everybody.
Sawadika.
สวัสดีครับ Bye bye from Bangkok.
Bye bye.
Bye-bye.
Bye.